Dr. Satyajit Sinha is the Chairman and Director of ABI Hospital, Patna, a leading anterior segment surgeon and member ARC East for the second term, and he has some wonderful teaching points. So let's hear from Dr. Satyajit.
I'd like to thank Dr. Chitra Ramamurthy for giving me this opportunity. This is a case of a 21-year-old person who was having recurrent redness. He was working on a lathe machine, and after 1 year he came to us, and on dilatation we saw this SINHA, and then we took him up for cataract surgery. We put in viscoelastic, and then after making the main incision, we gently try to remove the adhesions which are there, because we could see that there is a foreign body over there which was causing the reaction in the eye. Once we had removed the adhesions, then we wanted to clear the iris margin of whatever debris was there along the iris margin. And once we did that, then we wanted to slowly go in and remove the foreign particle which was there. It was a metallic part which had gone a year back in his eye, and the main corneal wound had self-sealed by itself. So this was the metallic foreign particle which was there in the eye. Once we had removed this, the anterior capsule was also ruptured and there was cataract. So we went ahead and started doing the rexis, because we wanted to take care of the cataract also. Because he was a young person, his anterior capsule was also elastic. And the other thing that we wanted to make sure is that whenever we are making the rexis in such kind of a case, the part which is ruptured has to be taken within the rexis that we make. So we slowly go around without making sure that it doesn't get extended also, and also that the torn part gets included within the rexis which we are making. And in these kind of cataracts, it's a very soft cataract. There is only cortex in the young individual. There is no nucleus in these traumatic cataracts and young person. So we go ahead now and do a hydrodissection. Before doing the hydrodissection, we remove the extra viscoelastic which is there in the anterior chamber, so that the fluid has space to come in the anterior chamber. Once you have done a good hydrodissection, then you, because it's a soft cataract, instead of going to the section of the function of quadrant, you can go straight to the cortex with your phaco probe and remove the cataract. You use the cortex function and remove the cortex which is there. And then once it has been dislodged, then you use the irrigation and aspiration, and then you can remove the remaining cortex which is there, which easily comes out through the main port also. You can clean the rest of the cortex which is there, and then an intraocular lens is implanted. Once you have done that, then you want to hydrate the wounds. You want to make sure that the AC is absolutely secure. You have to wash the anterior chamber with the extra viscoelastic which is there. And most importantly, you have to go behind the IOL also and remove the viscoelastic which is there, so that on the following post-op day, there is no spike in the intraocular pressure. So we go behind the intraocular lens and remove the viscoelastic which is there. And after this surgery, the patient had good vision also, and his recurrent redness was also taken care of.
Very
Thank
nice.
you very much.
Yeah, very nice surgery which you showed, Satyajit. The way you included the ALC tear and inside the CCC did well. Now, I would ask Dr. Namrata Sharma here, supposing there was a corneal tear. Now, this was a self-sealing tear, and it was 1-year-old case. Supposing there was an overlying corneal tear, Namrata, would you want to do both the surgeries at the same sitting, or would you do it at different sittings? Are you there?
Yeah. Corneal tear, if it is present, then I would like to do both the surgeries at different sittings first. If it's a large perforation or medium-sized perforation, first, suture the perforation first and take up this cataract surgery, unless the lens matter is there inside and it's kind of ruptured. But if it is a foreign body which is sitting there, which is metallic and which is in the lens and which is kind of inert, I would do the repair of the corneal perforation first and remove the foreign body and tackle the cataract at a later date.
Supposing that corneal tear had been in the visual axis itself, how would your biometry be managed?
So I think while putting the sutures itself, one has to be careful in the sense that, try and avoid the pupil just by the direction of the sutures, the way you put it. Then also change the length of the sutures, the short sutures, as well as the long sutures, which have to go. Biometry would become difficult in such cases. Goes
Other
without.
eye also then.
Other eye you may use, but here what would happen is that the keratometry of the affected eye would, would be changed and would be distorted. So that is an issue. But short of that, that is the only way, to go about it. Probably take the fellow eye keratometry and then exam you would already have.
Yes. So anything else, any of the expert panel have to comment before you go on to our next speaker?
The possibility of a posterior capsular rupture cannot be entirely ruled out by the imaging methods. So one has to be prepared again for a posterior capsular rupture in such cases. If it is not there, well and good. But if it is there, and especially with the possibility of an iron foreign body in place, which might actually fall off while doing the maneuvers, that definitely has to be kept.
We did an OCT to see the posterior capsules.
Yes, Satyajit. That's the answer.